for medullary thyroid cancer that is metastatic, not surgically resectable, and progressive, then there are 4 FDA-approved drugs in the United States for medullary thyroid cancer, namely vandetanib, cabozantinib, selpercatinib, and pralsetinib. And the first 2 are considered anti-VEGF or more anti-angiogenic therapies, and the latter 2, selpercatinib and pralsetinib, are RET inhibitors. And the 2 RET inhibitors have recently been FDA approved for RET altered thyroid cancers, so RET mutated medullary thyroid cancer in this case, whether it's hereditary or sporadic. Because they will not work, right, if you don't have a RET alteration. And so in this case, this patient has a RET mutation, and so you have all 4 choices for treatment, right? We know that the other 2 drugs also work if you have a RET mutation, but the RET inhibitors tend to have less anti-angiogenic activity. So we tend to think of a patient like this who has a RET inhibitor where surgery is going to be difficult, where the initial management typically would be surgery because the distant disease is not threatening right now, whereas the neck disease is to try to give a drug, shrink the tumor, and then go forward with surgery and decide whether you want to continue it after surgery. So when we think about neoadjuvant drugs, we ideally want to use less anti-angiogenic inhibition just because of wound healing and fistulas and things like that. So in this case, we'd have a discussion if Dr. Wong felt that, hey, it's better, potentially because of the membrane issue that was brought up or other organs, we would use one of the RET inhibitors first. And hopefully in a trial setting, right? Because this is not a proven technique, and then go forward with surgery.